Free audio post-production by alphonic.com.
Hi, I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we have an episode that has been requested by many of our listeners. We'll discuss what is possibly the most important of the perinatal infections, CMV, or cytomegalovirus. I wanted to start off with chatting about some of the dietary changes and other various precautions that women change when they fall pregnant.
Well, the most obvious is avoiding soft cheeses.
And what infection are we trying to avoid?
Listeria.
Exactly. Any other dietary changes?
Avoiding cured meats, pre-made salads, and especially raw meat.
And what infections are we trying to avoid with those changes?
That would be listeria and toxoplasmosis.
Anything else that pregnant women specifically change?
Usually stop drinking and reduce how much coffee they drink.
Exactly. Interestingly, none of these precautions are to prevent CMV, and yet CMV is the most common perinatal infection. There's been some research to support the fact that most pregnant women are unaware of the recommendations to prevent CMV, despite this being an important part of antenatal education. The recommendations verbatim from the RANSCOL guideline to reduce the risk of being infected with CMV include: do not share food, drinks, or utensils used by children, particularly under the age of 3. Do not put a child's dummy in your mouth. Avoid contact with saliva when kissing a child. Kiss on the forehead, not the lips. Thoroughly wash your hands with soap and water for 15 to 20 seconds, especially after changing nappies or feeding a young child or wiping a young child's nose or saliva. And clean toys, countertops, and other surfaces that come into contact with children's urine or saliva.
So, CMV is obviously a very important perinatal infection, and prevention is key. But what is it exactly?
Cytomegalovirus, or CMV, is a DNA herpes virus that eventually infects most humans. It was first observed by a German pathologist and was named because the infected cells appeared enlarged with big nuclei, hence the cytomega part of the name. Similar to other herpes viruses, after the primary infection, the virus becomes latent with periodic activation and viral shedding.
Now let's talk epidemiology. Congenital CMV affects between 0.2 to 2.5 of all births, or approximately 2,000 babies each year are infected with congenital CMV. But this doesn't necessarily mean they'll all be affected. We'll go into more detail about this. Approximately 50% of pregnant women will have evidence of a previous infection, i.e. they will be seropositive for CMV IgG. The highest transmission rate to the fetus will be with a maternal primary infection. However, there will still be a burden of congenital CMV from reactivation.
I'm sure you can infer from the prevention recommendations that we've mentioned how this virus is transmitted. It's secreted into all bodily fluids and transmitted through contact with infected saliva, semen, urine, blood, and nasopharyngeal and cervical secretions. With regards to the routes of vertical transmission, it's transmitted through the placenta during delivery and breastfeeding. There is no transmission with an amniocentesis.
What most parents, and clinicians for that matter, want to know is the likelihood of the baby being affected. We'll start with a primary infection. The mother-to-child transmission rate for a maternal primary infection is approximately 30%. This does change throughout each trimester. The transmission rate in the first trimester is between 30 to 35%, in the second trimester between 35 to 40%, and in the third trimester the transmission rate is between 40 to 70%. But to keep this simple, let's just say that the mother-to-child transmission rate is approximately 30%.
Okay, so those 30% now have congenital CMV. Of these infected babies, 85 to 90% will be asymptomatic and only 10 to 15% will be symptomatic. Of the 10 to 15% of symptomatic babies, there's a 50-50 chance of them having any long-term sequelae, with 50% being normal. Of the 85 to 90% of asymptomatic babies with congenital CMV, there's an 85 to 90% chance of them having a normal outcome. In these babies, only 10 to 15% will have any long-term sequelae.
And what if there's maternal reactivation or reinfection with CMV?
In this case, that's a much lower rate of transmission and a much lower rate of having an affected child. There's approximately a 1% chance of transmission of congenital infection, and of those with a congenital infection, there's a 1% chance of symptomatic congenital CMV. Of those with either symptomatic or asymptomatic congenital CMV, there's about a less than 10% risk of long-term sequelae.
That is a lot of numbers.
Yeah, so all of these numbers are from the 2019 ACID guideline. We'll put the flow chart in our summary slides because it's much easier to kind of picture with the flow chart as a quick reference. Overall, the long-term risk of sequelae in a congenitally affected child is 10 to 20%. Who's at highest risk of getting CMV?
The highest risk groups are daycare workers and parents with children in daycare. These two groups have the highest annual seroconversion rates. Healthcare workers are not specifically at higher risk and have similar annual seroconversion rates to the general population. So who should we test for CMV serology?
So currently, RANZCOG does not recommend universal screening for CMV serology. This was included as a part of their updated 2023 guideline. Pre-pregnancy or early pregnancy screening with CMV IgG may be considered in higher risk groups, i.e. daycare workers or parents with children in daycare. For those that are IgG negative, it encourages women to be strict with hygiene measures. It also helps to interpret serology if it's repeated throughout the pregnancy because of a suspected infection. For women who test for IgG positive, it's still important to remember that they can get reinfected and adherence to hygiene practices is essential. Some possible indications for testing for CMV during pregnancy include a maternal history of symptoms suggestive of CMV, contact with a known case of CMV, or ultrasound features suggestive of a possible infection. Most people infected with CMV will be asymptomatic. Other symptoms include fever, pharyngitis, lymphadenopathy, and polyarthritis. Those with immunosuppression may have a more severe illness that includes myocarditis, pneumonitis, hepatitis, retinitis, gastroenteritis, and meningoencephalitis. Interestingly, a new European consensus statement that's been published in 2024 in the Lancet Regional Health has different guidelines about who to screen. It was written by the European Congenital CMV Infection Initiative. I'm not sure which countries this applies to, but I assume it's kind of similar to our ACID guidelines, like a reference guide. If anyone's listening from Europe who can shed some light on this, we'd greatly appreciate it. But anyway, their screening recommendations differ from ours, and they recommend to perform CMV serology in the first trimester of pregnancy or as early as possible, followed by, in seronegative women, a retest every 4 weeks until 14 to 16 weeks. CMV serology is then not recommended in pregnant women beyond 16 weeks unless there are ultrasound features of CMV-compatible symptoms.
These changes in recommendations to screening in Europe are likely because we now have a treatment for the prevention of vertical transmission of congenital CMV. We'll go into the specific details later in the episode. I wouldn't be surprised if Australian guidelines update over the next few years as well. I know there's further research happening in Australia to look into the feasibility of universal screening within a local context. But it's time for a little summary, I reckon.
Okay, so cytomegalovirus is a DNA herpes virus. Patients can have a primary infection or reactivation or reinfection with CMV. The virus is transmitted through contact with infected bodily fluids, and vertical transmission occurs through transplacental passage during delivery and with breastfeeding. The highest risk period for vertical transmission with possible severe and long-term sequelae for the fetus and neonate is with a maternal primary infection during the first trimester or at periconception. The rate of vertical transmission is about 30%, with an overall risk of long-term sequelae in a congenitally infected child of 10 to 20%. These rates do depend on if it was a primary infection or reactivation or reinfection, and when during the pregnancy the infection occurred.
Prevention is essential, and all people attempting to conceive or during pregnancy should be educated on the following advice. Don't share food, drinks, or utensils used by children under the age of 3. Don't put a child's dummy in your mouth. Avoid contact with saliva when kissing a child, and kiss on the forehead, not the lips. Thoroughly wash your hands with soap and water for 15 to 20 seconds, especially after changing nappies or feeding a young child or wiping a young child's nose or saliva. Clean toys, countertops, and other surfaces that come into contact with children's urine or saliva.
Currently in Australia, universal screening for CMV is not recommended. In high-risk groups, such as daycare workers or parents with children in daycare, pre-pregnancy or early pregnancy screening with CMV IgG may be considered. For those that are IgG negative, it encourages women to be strict with hygiene measures. It also helps to interpret serology if it's repeated throughout the pregnancy. For women who test positive for IgG, however, it's still important to remember that they can get reinfected, so adherence to hygiene practice is still essential. Some possible indications for testing for CMV during pregnancy include a maternal history of symptoms suggestive of CMV, contact with a known case of CMV, or ultrasound features suggestive of a possible infection.
Okay, why don't we consolidate some of our knowledge? Let's follow a patient through their pregnancy journey. Let's meet Ayla. Ayla is a 20-year-old primate who is currently 20 weeks pregnant. She's a daycare worker, and her work usually has provisions for pregnant patients to not work with children 3 years and under, but unfortunately this was an unplanned pregnancy. She underwent her routine morphology ultrasound and has been referred to your maternity assessment centre with the result. The summary of her morphology ultrasound report reads, there is some mild ventricular megaly with intracerebral calcifications. The rest of the morphology is unremarkable within the limits of ultrasound, suggest obstetrician referral. Okay, Carla, she's rocked up to your assessment centre. What are you going to do?
Well, first I'm going to review her history. Gravida, parity, and estimated due date. Her past medical and surgical history, allergies and medications. Her smoking status, alcohol, recreational drug use and her occupation. And her pregnancy to date. So blood group and antibody screen, serology and rubella status, and if she's had any aneuploidy screening or genetic carrier screening. Now, I know that ventricular megaly and intracranial calcifications are concerning for a possible perinatal infection, so I'm going to see if she's had any infectious symptoms during this pregnancy and check her exposures. Next, I do an examination. Check her vital signs, height, weight and BMI, check her fundus and fundal height and fetal heart rate. And for investigations, I'd arrange a torch serology, noting that the yield of each of these tests is limited, and most important of these being CMV.
Okay, just going to pause here for a bit. So I'm sure you'll all remember from the mini evidence with Anne discussion we had about torch screening utility in toxoplasmosis. But for those who don't remember, I'll do a quick summary. So there was an article published in 2022 titled A Systematic Review of Maternal Torch Serology as a Screen for Suspected Fetal Infection. Essentially, the review included 8 studies, over 2,500 patients. They commonly included indications for torch screening such as polyhydramnios, fetal growth restriction, ultrasound abnormalities including hyperechogenic bowel. There were only 31 cases of confirmed congenital infections, and of those, 26 were confirmed cases of congenital CMV with 5 cases of parvovirus. So you can see the importance with this patient and this podcast episode where CMV is clearly the most common perinatal infection when we're using a torch screen. 15 of the cases of congenital CMV had multiple ultrasound anomalies. Okay, so back to our patient.
Exactly. Since I knew about this review, I also arranged parvovirus serology. But since CMV was the most important, I ensured that both CMV IgG and IgM were tested. I referred the patient to maternal fetal medicine and patiently waited for the results to come back.
So now, Mel, it's 2 days later and you receive a phone call from pathology to inform you that the patient's results likely indicate a recent primary maternal CMV infection. Pathology informs you that both of Ayla's CMV IgG and IgM are positive. What do we do next?
CMV serology can be tricky to interpret, so let's break it down for a bit. If IgG and IgM are both negative, the patient is CMV susceptible. If we are clinically concerned, then it should be repeated. If there is seroconversion on repeat serology, then this is a confirmed primary infection. If IgG is positive and IgM is negative, that suggests a past infection. But if both are positive, as it is with Ayla, further testing with CMV-specific IgG avidity is needed to distinguish recent from past infection.
And let's not forget, CMV IgM can persist for months and may even reappear with reinfection or reactivation. False positives do happen in some cases with cross-reaction from other herpes viruses.
Okay, so if the CMV avidity comes back as low, then this is a confirmed primary infection. Avidity is really just testing the strength of an association. I like to remember it by the fact that essentially the CMV hasn't been around for very long because it's a primary infection, and so the strength of association or attraction is low, thus the avidity is low. But for a past infection, the avidity is high because it's been around for a while.
What about if the serology comes back as CMV IgG negative, but IgM positive?
Okay, well, in this case, you should repeat the serology in about 2 weeks. If the IgG becomes positive, then it is a confirmed primary infection. If the IgG remains negative, then it's either a possible recent infection or it could be a false positive IgM. So for Ayla, her serology comes back with low IgG avidity, suggesting a confirmed maternal primary infection. The next step is referral to maternal fetal medicine for a tertiary ultrasound and consideration of amniocentesis. This is to determine if there is a confirmed fetal infection. Now, Anne, what are some of the ultrasound features of congenital CMV?
Sonographic findings of congenital CMV include microcephaly, ventriculomegaly, cerebral calcifications, ascites, hepatomegaly, splenomegaly, abdominal calcifications, hypoechoic bowel, hydrops, oligo or polyhydramnios, and fetal growth restriction. I like to remember them by the usual fetal infection things, which includes all the brain stuff, microcephaly, ventriculomegaly, and cerebral calcifications, as well as hypoechogenic bowel and FGR. And then all the hematological/hydrops things, which includes ascites, pleural and pericardial effusions, hepatomegaly, splenomegaly, oligo or polyhydramnios, or hydrops.
I'm sure most parents would be very anxious and really want to know how this is going to affect their baby. But it's important to note that at this point, the presence of any of these ultrasound findings in the context of congenital CMV does not necessarily predict the degree of fetal damage. The sensitivity of a fetal ultrasound is only approximately 30 to 50% in detecting a symptomatically infected infant. A fetal MRI is not routine, but it may be considered in the context of a confirmed congenital CMV infection. Generally speaking, ultrasound and the results of an amniocentesis are used to confirm the diagnosis of a fetal infection. An amniocentesis is best done at least 6 weeks after a confirmed maternal infection and from 21 weeks and above. The amniotic fluid is tested for CMV PCR.
Why is this? Why not just do the amnio as soon as maternal primary infection is confirmed?
And you're going to love this because it's to do with stats. The sensitivity improves from 45% if the amnio is done less than 20 weeks to 80 to 95% if it's done after 21 weeks. The specificity is between 97 to 100% with a positive predictive value of close to 100%.
I think some of that's got to do also with when the CMV is excreted into the amniotic fluid. So the CMV needs to be excreted into the amniotic fluid from the fetal kidney. So you need to have functioning fetal kidneys and enough of the CMV virus in the amniotic fluid. So generally before 20 weeks, you're not going to get enough fetal renal function to transmit the CMV into the urine, is my understanding. All right. So is a cortocentesis ever done to collect fetal blood to check for CMV serology?
Well, no, a cortocentesis is not recommended as it doesn't improve the diagnostic yield and is a much riskier procedure.
Okay, let's do another summary. So cytomegalovirus is a DNA herpes virus. Patients can have a primary infection, reactivation, or reinfection with CMV. It's transmitted through contact with infected bodily fluids. Vertical transmission occurs through transplacental passage, during delivery, and breastfeeding. The highest risk period for vertical transmission with possible severe and long-term sequelae for the fetus and neonate is with a maternal primary infection during the first trimester or periconception. The rate of vertical transmission is approximately 30%, with an overall risk of long-term sequelae in a congenitally infected child of approximately 10 to 20%.
And these rates do depend on if it was a primary infection or a reactivation or reinfection and when during the pregnancy the infection occurred.
Prevention is essential, and all people attempting to conceive or during pregnancy should be educated on the following advice. Do not share food, drinks, or utensils used by children, especially under the age of 3. Don't put a child's dummy in your mouth. Avoid contact with saliva when kissing a child and kiss them on the forehead, not the lips, if you have to kiss them at all. Thoroughly wash your hands with soap and water for 15 to 20 seconds, especially after changing nappies, feeding a child, or wiping their nose or saliva. And make sure you clean toys, countertops, and other surfaces that come into contact with children's secretions.
Currently in Australia, universal screening for CMV is not recommended. In high-risk groups, such as daycare workers or parents with children in daycare, pre-pregnancy or early pregnancy screening with CMV IgG may be considered. For those that are IgG negative, it encourages women to be strict with hygiene measures. It also helps to interpret serology if it's repeated during the pregnancy because of a suspected infection. For women who test positive for IgG, however, it is still important to remember that they can get reinfected, so adherence to hygiene practices is still essential. Some possible indications for testing for CMV during pregnancy include maternal history of symptoms suggestive of CMV, contact with a known case of CMV, and/or ultrasound features suggestive of a possible infection.
Sonographic findings of congenital CMV include microcephaly, ventriculomegaly, cerebral calcifications, ascites, hepatomegaly, splenomegaly, abdominal calcification, hyperechoic bowel, hydrops, oligo or polyhydramnios, and fetal growth restriction.
For CMV serology, both IgG and IgM are tested. If IgG and IgM are both negative, then the patient hasn't been infected before and is CMV susceptible. If we are clinically concerned about a recent infection, then the IgG and IgM should be repeated. If there is seroconversion on repeat serology, then this is a confirmed primary infection. If IgG is positive and IgM is negative, that suggests past infection. But if IgG and IgM are both positive, further testing with CMV-specific IgG avidity is needed to distinguish recent from past infection. If the CMV IgG avidity comes back as low, then this is likely a recent primary infection. If the CMV IgG avidity is high, then this suggests a previous infection. If the CMV IgG is negative, but the IgM is positive, then you should repeat the serology in about 2 weeks. If the IgG becomes positive, then it's a confirmed primary infection. But if the IgG remains negative, then it could be a recent infection, or it may be more likely to be a false positive IgM.
If a patient has a confirmed primary infection, then referral to maternal fetal medicine is indicated to consider an amniocentesis to confirm the diagnosis of a fetal infection. An amniocentesis is best done at least 6 weeks after confirmed maternal infection and from 21 weeks and above. The amniotic fluid is tested for CMV PCR. A fetal MRI is not routine, but it may be considered in the context of a confirmed congenital CMV infection with ultrasound abnormalities. The presence of any of these ultrasound findings that we've mentioned, and/or a positive CMV PCR on amniocentesis in the context of a congenital CMV infection, doesn't necessarily predict the degree of fetal damage. And a chordocentesis is not used to diagnose congenital CMV.
Okay, back to Ayla. So she underwent a tertiary ultrasound and amniocentesis, which has come back as, drumroll, a positive a CMV PCR, thus confirming a congenital CMV infection. So what's next? What are her options?
Well, first it's important for Ayla to have some expert counselling. As with ultrasound, a positive PCR on amniocentesis does not predict the degree of fetal damage and long-term sequelae. For Ayla, we would consider her fetus to have symptomatic congenital CMV, which has a 50% risk of long-term sequelae and a 50% chance of being normal. The sequelae associated with symptomatic congenital CMV includes a 5 to 10% chance of mortality within the first 3 months, a 35 to 50% chance of neurological sequelae of microcephaly, including 10% with seizures, 10 to 20% with chorioretinitis, and up to 70% with developmental delay. And there's also a 25 to 50% chance of sensory neural hearing loss, with progression expected in about half of these cases.
And what about those cases with asymptomatic congenital CMV? So it's been diagnosed, but there's no features on ultrasound.
So those with asymptomatic congenital CMV have about a 10 to 15% chance of long-term consequences. These include about 5% with sensory neural hearing loss, with progress in about half, and 2% with chorioretinitis. The risk of clinical outcomes for the fetus does change throughout the trimesters. For Ayla, because there is evidence of infection at her morphology ultrasound, we are assuming that her primary infection occurred during the first half of the pregnancy. The risk of a severe adverse neurological outcome is more likely with primary infection in the first half of the pregnancy, whereas a fetus infected later in the pregnancy is more likely to have acute visceral disease, such as hepatitis, purpura, and thrombocytopenia.
I've heard of something called congenital CMV syndrome. What's that?
So congenital CMV syndrome is a constellation of fetal and neonatal clinical features, which includes fetal growth restriction, microcephaly, intracranial calcifications, chorioretinitis, mental and motor retardation, hemolytic anemia, sensory neural deficits, hepatosplenomegaly, jaundice, and thrombocytopenic purpura. But back to Ayla. We have provided her with information about the possible consequences for her baby. So what's next?
So, after confirming her fetal infection, Ayla should be counselled about prognosis, as we've mentioned, and the option of continuing the pregnancy or termination of pregnancy. For those continuing the pregnancy, a multidisciplinary team approach is key. Maternal fetal medicine, a high-risk obstetric clinic, and neonatology. We should arrange for serial growth ultrasounds.
Now, delivery timing and mode of delivery aren't influenced by CMV unless complications arise, and breastfeeding should be encouraged. Other delivery considerations include sending the placenta for histopathology and specifically looking for CMV inclusion bodies. The pediatric or neonatal team should be informed either antenatally or around the time of delivery because postnatal testing and follow-up of the baby does need to be arranged. The neonatal assessment includes a physical examination at birth. Investigations include a newborn hearing screen, CMV PCR from urine and saliva. The saliva sample should be taken at least 1 hour after breastfeeding to avoid maternal contamination. The CMV PCR testing must be done less than 21 days and ideally less than 14 days. If the CMV PCR is positive, then the neonate is classified as having confirmed congenital CMV. Other tests that may be useful but not diagnostic alone include a full blood count and differential and liver function tests. Babies will also require an ophthalmology assessment and head imaging, including a head ultrasound and MRI. The results of these further investigations will determine whether or not the neonate is started on antiviral treatment. Essentially, if the neonate is symptomatic, then they get 6 months of valganciclovir.
We mentioned earlier that the clinical sequelae for the infant may not be identified immediately after birth. These babies thus require long-term follow-up. The clinical follow-up as suggested in the ACID guidelines include regular audiology, ophthalmology, and pediatric assessments until 6 years of age. The rest of Ayla's pregnancy, however, was uncomplicated. She went on to have a spontaneous labour and vaginal birth at term. Her baby was asymptomatic at birth and is currently getting further investigations and long-term follow-up. And I thought there was now a treatment for congenital CMV.
In the last 5 years, there's been some data published on the use of valacyclovir to prevent vertical transmission after a maternal primary infection. In 2020, The Lancet published an RCT by Shaharnissen et al. This was followed by a 2023 individual patient data meta-analysis by Chatzakis. Sorry if I pronounce your name incorrectly. And this is in the American Journal of Obstetrics and Gynecology, which included that RCT I just mentioned and 2 other quasi-randomized studies. These papers evaluated the use of valacyclovir to prevent vertical transmission of cytomegalovirus after a maternal primary infection during pregnancy. The population group were women who acquired a primary CMV infection, periconception, or during the first trimester. This was diagnosed by seroconversion, so the patients did get multiple blood tests, preconception, and throughout the first trimester. Those patients with a confirmed primary infection were randomized to 8 grams per day of valacyclovir or placebo. Just for reference, 8 grams per day is 16 tablets per day. The results from the meta-analysis, which included the data from the Lancet RCT, showed that treatment with valacyclovir reduced the rate of CMV-positive amniocentesis with an adjusted odds ratio of 0.34, confidence interval between 0.18 to 0.61. It reduced the rate of a neonatal infection with an adjusted odds ratio of 0.3, a 95% confidence interval of 0.19 to 0.47. And it also reduced the rate of a termination of pregnancy due to CMV-associated severe fetal findings.
How amazing. This brings us back to the discussion around universal screening. So we now have a treatment that we can offer patients, but it's only effective after we've diagnosed a primary infection and before the baby gets infected. So how do we screen everyone for this?
Exactly. And so I think that's why the European guidelines have changed, and that's what they suggest. So they suggest to screen everyone and then treat those with a maternal primary infection. So watch this space in Australia. The main side effect of the high-dose valacyclovir is a 2% rate of renal impairment, so it's suggested to give the dose in 2 divided doses. I have had to prescribe this before, actually. I only had to do the ongoing prescription. I think MFM had decided to treat a patient, and it was quite complicated. I had to get approval from the hospital, and the patient definitely had to get it filled by the hospital pharmacy, given the number of tablets the patient needed.
Yeah, wow. It's important to think about those logistics and having to take 16 tablets every day. You don't think about the actual act of prescribing it and then giving it. So that's a really good point. And let's get back to Ayla. Is there anything else we need to counsel her about for the next pregnancy?
Yeah, well, we mentioned earlier that the highest risk time for a maternal primary infection for congenital CMV is at the time of periconception and during the first trimester. Well, the highest risk time is actually 1 year after a maternal primary CMV infection, but the risk can persist for up to 4 years. It is important to counsel patients appropriately and to consider contraception and delaying conception. For Ayla, she continued her pregnancy, so hopefully there would be at least 1 to 2 years after her primary infection before her next pregnancy. Many people, however, would consider a termination and are understandably often wanting to try for another pregnancy soon after.
Okay, guys, this has been a mammoth of an episode. So let's do one final summary. Cytomegalovirus is a DNA herpes virus. Patients can have a primary infection, reactivation, or reinfection with CMV. It's transmitted through contact with infected bodily fluids, and vertical transmission occurs through transplacental passage, during delivery, and breastfeeding. The highest risk period for vertical transmission with possible severe and long-term sequelae for the fetus and neonate is with a maternal primary infection during the first trimester or periconception. The rate of vertical transmission is approximately 30%, with an overall risk of long-term sequelae in a congenitally infected child of about 10 to 20%. These rates, however, do depend on if it was a primary infection or reactivation or reinfection, and when during the pregnancy the infection occurred.
Prevention is essential, and all people attempting to conceive or during their pregnancy should be educated on the following advice. Do not share food, drinks, or utensils used by children. Don't put a child's dummy in your mouth. Avoid contact with saliva when kissing a child. Consider kissing on the forehead. Thoroughly wash your hands with soap and water for 15 to 20 seconds, especially after changing nappies or feeding a young child, or wiping a child's nose or saliva. Clean toys, countertops, and other surfaces that come into contact with children's urine or saliva.
Currently in Australia, universal screening for CMV is not recommended. In high-risk groups like daycare workers or parents with children in daycare, pre-pregnancy or early pregnancy screening with CMV IgG may be considered. For those who are IgG negative, it encourages women to be strict with hygiene measures. It can also help to interpret serology if you need to repeat it during the pregnancy because of a suspected infection. For women who test positive for IgG, however, it is still important to remember that they can get reinfected, so adherence to hygiene practices is still essential. Some possible indications for testing for CMV during pregnancy include maternal history of symptoms suggestive of CMV, contact with a known case of CMV, or ultrasound features suggestive of a possible infection.
Sonographic findings of congenital CMV include microcephaly, ventriculomegaly, cerebral calcifications, ascites, hepatomegaly and splenomegaly, abdominal calcification, hyperechoic bowel, hydrops, oligo or polyhydramnios, and fetal growth restriction.
For CMV serology, IgG and IgM are tested. If the IgG and IgM are both negative, then the patient is CMV susceptible. And if we're clinically concerned, then we should repeat the serology. If the seroconversion on repeat serology, then this is confirmed primary infection. If the IgG is positive and the IgM is negative, then this suggests a past infection. If the IgG and IgM are positive, further testing with CMV-specific IgG avidity is needed to distinguish from past infection and recent infection. If the CMV IgG avidity comes back as low, then this is a confirmed primary infection. If the CMV IgG avidity is high, then this suggests a previous infection. If the CMV IgG is negative but the IgM is positive, then you should repeat the serology in approximately 2 weeks. If the IgD becomes positive, then this is a confirmed primary infection. If the IgD remains negative, then it's a possible recent infection, but it also could be a false positive IgM.
If a patient has a confirmed primary infection, then referral to maternal fetal medicine is indicated to consider an amniocentesis to confirm the diagnosis of a fetal infection. An amnio is best done at least 6 weeks after confirmed maternal infection and from 21 weeks and above. The amniotic fluid is tested for CMV PCR. A fetal MRI is not routine but may be considered in the context of a confirmed congenital CMV infection with associated ultrasound abnormalities. The presence of any of these ultrasound findings that we've mentioned and/or a positive CMV PCR on amniocentesis in the context of congenital CMV does not necessarily predict the degree of fetal damage. And finally, a cortocentesis is not used to diagnose congenital CMV.
Management includes expert counselling. Options include termination of the pregnancy or continuing the pregnancy with expectant management. If continuing the pregnancy, then a multidisciplinary team should be involved, including maternal fetal medicine, high-risk obstetrics, and neonatology, and we should arrange for serial growth ultrasounds. Counselling should include ultrasound and positive PCR on amniocentesis do not predict the degree of fetal damage and long-term sequelae. For symptomatic congenital CMV, which has a 50% of long-term sequelae and a 50% chance of being normal. The sequelae associated with symptomatic congenital CMV include a 5 to 10% chance of mortality within the first 3 months, a 35 to 50% chance of neurological sequelae of microcephaly, including 10% risk of seizures, 10 to 20% of chorioretinitis, and up to 70% with developmental delay. There is also a 25 to 50% chance of sensory neural hearing loss, with progression expected in about half of these.
Those with asymptomatic congenital CMV have approximately a 10 to 15% chance of long-term sequelae. These include approximately 5% with sensory neural hearing loss, with a progression in about half of these, and 2% with chorioretinitis. The risk of clinical outcomes for the fetus changes throughout the trimesters. The risk of a severe adverse neurological outcome is more likely with a primary infection in the first half of the pregnancy, whereas a fetus infected later in the pregnancy is more likely to have acute visceral disease such as hepatitis, purpura, or thrombocytopenia.
Congenital CMV syndrome is a constellation of fetal and neonatal clinical features which includes fetal growth restriction, microcephaly, intracranial calcifications or chorioretinitis, mental and motor retardation, hemolytic anemia, sensory neural deficits, hepatosplenomegaly, jaundice, or thrombocytopenic purpura.
Intrapartum and postpartum considerations include sending the placenta for histopathology and specifically requesting CMV inclusion bodies, that breastfeeding is safe, informing the paediatric or neonatal team, and having a neonatal assessment that includes a physical exam at birth. Investigations include a newborn hearing screen, CMV PCR from urine and saliva. If the CMV PCR is positive, then the neonate is classified as having confirmed congenital CMV. So other tests include a full blood count and differential and LFTs. The neonate will require an ophthalmology assessment and head imaging, including a head ultrasound and MRI. Essentially, if the neonate is symptomatic, then they get 6 months of antivirals. These babies require long-term follow-up, including regular audiology, ophthalmology, and pediatric assessments until 6 years of age.
For treatment, in those with an early diagnosis of maternal primary CMV, then the use of high-dose valacyclovir can reduce the risk of congenital CMV.
And it's important to counsel the patient that the highest risk time for vertical transmission of CMV is within the first 12 months after a maternal primary CMV infection. So women with primary CMV should be counseled to avoid pregnancy for this time.
And that wraps up today's episode of the Uterine Sound.
See you next time.
Bye for now. Thanks for listening. And don't forget to subscribe for more discussions on all things obstetrics and gynecology. You'll find our summary slides on Instagram later in the week. Check out our website, www.theuterinesound.com, email us at theuterinesound@gmail.com, and find us on socials at The Uterine Sound.
Free audio post-production by alphonic.com.